That's a great question. Our surgeons are starting to do that sort of reflexively. So many of my early stage patients who come to see me have already had EGFR and KRAS testing done and know the results, which then leads to a discussion about what do we do with that information. In the adjuvant setting, we have had a trial open that takes patients with known EGFR mutations and offers them adjuvant or erlotinib. And so with the trial open, we had an avenue to go. Since that trial has now closed to accrual, I am not offering those patients adjuvant or erlotinib off of a trial. With the KRAS data, we just talk about it. I don't think it has any implications for their treatment as far as whether or not to offer them adjuvant chemotherapy. Where that issue comes up a bit more is in the locally advanced or stage 3 patients, as you had mentioned. And I still will offer them standard treatment with chemotherapy and or radiation and or surgery depending on the patient. And haven't really used the molecular information very often. Where I have thought about it and on occasion have utilized that information are in patients with very large tumors who have a known EGFR mutation, where I know that I'm going to have a better likelihood of shrinking their tumor quickly using the EGFR TKI. However, we really do need a lot more data in that setting, especially when you're bringing the radiation in. I think that there's a real risk for the pneumonitis with radiation and EGFR TKIs, and we haven't really explored that question well enough to be able to put numbers on it or have a true discussion of risk-benefit with the patient in that context.